Hello, super awesome, super cool Econ 345 students. Today we're going to be talking about health insurance. So how health insurance kind of plays on the national stage and what things are being done at the national level to address healthcare in America. So if you really enjoy the lessons from this week, you should probably consider taking the health economics class. It's actually a lot of fun as well. That one's taught by Marlon Tracy. Don't tell him I said that he's fun though, because I'll never hear the end of it. Okay, let me go ahead and share the screen. There we go. You'd think I'd be faster at this after quite a few months of doing it. So, health insurance. Let's talk about this. So in the United States, healthcare spending as a percentage of GDP is actually extremely large. We spend a lot of money on healthcare, which is kind of confusing because a lot of people think that we don't. They're like, oh, well, you don't have a state-sponsored healthcare system for everybody, so therefore you must not be spending a lot on healthcare. But it turns out we actually do. By percentage of GDP, we're one of the highest percentage spending countries in the world. So why isn't healthcare more efficient? Well, that's something to think about. A lot of this is because of where the money gets spent. So in the United States, we spend about 12% on prescription drugs or financing prescription drugs, especially for people who cannot necessarily afford them. About 23% goes to physician and clinician services, because these aren't government workers, right? These are independent people who make their income by charging the insurance groups that they work with. Then there's hospital care, home health care, nursing care, other personal care. So healthcare is a wide variety of things. It's not just what money goes to your doctor. It's thinking about everything from the monthly drugs that you pick up from your pharmacist all the way over to what do you do when you are an elderly individual who can no longer take care of themselves and you might need a nursing home or some sort of home health aid. It has a wide variety of different pieces within it. So in the United States, let's compare ourselves to a couple other countries real fast. So on this screen, notice that we have the United States, Canada, United Kingdom, Germany, and France. Okay. So what we see is that in the United States, we actually have the highest healthcare spending per person by far, right? Lots of healthcare spending, but at the same time, we see that we also tend to rank high in infant deaths. We actually have a huge amount of infant deaths that happen in the United States that don't necessarily happen in other countries. A lot of this is due to the lack of preventable care or preventative care or maternal care during the time of pregnancy. We also have higher rates of potentially preventable deaths. We have lots of people who go every single year without going to the doctor or dealing with their healthcare issue because of cost. I mean, I know I definitely was in that point when I was a student that it was just too expensive to go to the doctor, so sometimes I didn't, even if I really needed stitches or things like that. We see that we have lots of people who have to wait 6 or more days to end up seeing a doctor. So why does this happen? Why do we spend so much money yet we're still running into problems such as high infant death rates? Well, that's because there's a lot of inefficiencies in the U.S. healthcare system, right? There's some great and wonderful parts like research and development and new drugs and new ideas. But there's also a lot of inefficiencies that are happening that cause the system to lag behind other countries internationally. For example, we have some of the highest per person healthcare costs in out of the set of countries that we're looking at. We have high infant mortality rate, we have high preventable death rate, and a lot of that's because of this. So notice that out of all the money that we're spending on healthcare, so much of it goes to fraud. So we have large pieces of fraud, missed prevention opportunities, inefficient delivered services, prices that are too high compared to what market demands and market supplies are, unnecessary services, excessive administrative cost. So think about the last time that you went into a doctor's office and you have to talk to the person at the very end who handles the finances. Well, that person has a job for a reason, right? Because they have to call your insurance company, the insurance companies that they work with. They have to check everything against the PPO and the HMO to see if they're a provider in network or out of network. They have to contact all the other facilities that you've been seeing. They have to process these payments. And then when they process the payments, they have to figure out what sort of payment reschedule they get back from the insurance company. So do they get it immediately? Is it something that the patient has to pay up front and then it gets reimbursed later? What does that structure look like? These are a lot of pieces, right? And when you're dealing with hundreds of different insurance companies, you end up losing a lot of money to admin costs because you have to end up just hiring more people and getting more computer systems and just having more physical time that goes into even managing the bills, right? No one seems to think about how much just medical billing takes in time and effort and resources, but it's a lot, right? So this wasted administrative spending. The cost of admin for private insurance in the United States is about 15% more than twice the average of other developed nations, right? So take the admin cost of like Germany per person, multiply it by 2, add 15%, and then you have about the rate of the United States. So healthcare providers that have different private and public owners and have to deal with multiple private and public healthcare payers spend a huge amount of money on billing and collecting payments. It just takes a lot of time and a lot of effort to figure out exactly who to bill when it comes to the insurance, exactly who to bill when it comes to the patient. If someone overpays, how do you give it back to them? If they underpay, how do you collect from them? Do you go through the legal system? Do you sue them for that money? Or do you end up just giving them continuous payments? Do you mail, or do you sell off that debt to a debt collection agency for pennies on the dollar? Well, it depends, right? And it's a very, very complicated system. A recent study actually found that hospitals spend about 1.43% of GDP, right? So think about GDP. Now think of 1.43% of the GDP that's generated by hospitals, and that's admin cost. That's just processing bills and collecting payments. That's not servicing patients. That's not doing surgeries. That's not doing outreach. That's not doing marketing. That is admin cost, right? Also in the United States, we tend to have very high drug costs, right? So other nations impose really strict regulatory controls on what the prices of medical services can be. While in the United States, that's not necessarily the case, right? And here we have patent systems where you can keep a patent on a particular medical drug for years before generics can come out of it or other brands can start producing it. We also allow for advertising of medicine, which I think is only legal here in New Zealand. So this has a lot of costs that are associated with it, because as you're advertising your particular type of pill or medicine, then the cost for that pill or medicine goes up, and then you have to transfer some of that to the people, right? But there's two sides of this, right? Though we don't have these strong regulatory controls, it means that our prices are a lot higher, but we also have an availability of medicine that's not necessarily available everywhere else, because a lot of drug companies do locate in the United States because they can make more profit and they can have higher costs. So they can offset a lot of the cost of research and development and designing new drugs, because they know that they can sell them for higher prices for a limited purpose of time, as long as the patent's acceptable. So medical goods and services in the United States reflect kind of this hybrid mix of public price setting, what you're telling people the prices are, and private competition, where what you're actually selling it to this insurance company might be a different price than the listed price, and then that has to be debated between the pharmacist and the hospital and your individual insurance to come up with what the payer amount is versus how much the insurance is covering of it versus how much you pay out of pocket. And because of this system and how complicated it is, it tends to result in much higher overall prices when it comes to different drug costs in the United States. So a lot of you are probably like, I'm still on my parents' health insurance, right? Because in the United States, you can stay on your parents' health insurance until the age of 26. And I think if you don't have parents' health insurance, that there is school options of health insurance available, because the school does require that you have health insurance, right? So you may not know exactly how the health insurance system works. So I'm going to go through the basics, and we're going to kind of talk about what these different pieces are so that you have an idea. This is really important because you take this class because you want a degree to eventually get a job, right? Jobs are important. And when you get a job, they're going to give you a list of potential insurance plans, and you're going to have to pick one. You need to be able to read what those insurance plans are. So let's talk a little bit about it. So you, as an individual, or a company on your behalf, end up paying a monthly premium to an insurance company. This is a monthly payment for you to maintain insurance, right? Some of us pay it out of pocket. Some of us have it deducted from our check. Some of it, our company ends up paying their healthcare costs for us, so we don't necessarily have to pay it out of pocket. In return for these premium payments, insurance companies pays the providers of medical goods and services. So if you go to the doctor, that's a provider of medical goods and services, and your insurance company pays them a certain amount for the different types of things you get done. So they'll pay so much for a shot, they'll pay so much for, let's say it's dental insurance, they'll pay so much for a cavity, they'll pay so much for you to have a broken bone set. And then the provider, they have a cost, or they have a price, right? And this price, a percentage of it's going to be paid by your insurance, or the whole thing might be covered by your insurance. And then whatever little bit's remaining, that's what you're in charge of paying, right? So there's 3 different types of patient payments. The money that comes out of your pocket, right? Besides the premium payments, I'm talking about like within the system. First is the deductible. I'm sure many of you have gone to the hospital to get something done and you end up having a bill because they said, you haven't met your deductible yet. And then once you meet your deductible, this is why a lot of people get a ton of medical work done in October, November, December. It's because they've already met their deductible. Their deductible is the limit of cost to individual payers. So let's say that a company says your deductible is $750. Well, that means I'm responsible for paying my medical care up to $750, right? But once I hit that $750, my insurance company covers the rest. So let's say that I met my $750 for the year. I paid my $750 in insurance. Well, let's say that I can get a lot of other medical things done. I can go get some routine checks. I can go get some testing done. That would normally cost me money, but I've already met my deductible. That means that my insurance is going to cover the full cost of the rest of these things. So I'm going to want to go do them at that time. Your deductible is just the limit to the total amount that you're going to have to pay. Okay. And the next one is the idea of your copayment. Your copayment are fixed payments that you're going to pay. This is when okay, so a lot of us, actually, never mind, I'm not about to show my insurance card on camera, but on my insurance card, it says like Alicia Plemons, my number, my member, our group ID, because I get my insurance through my employer, and then it has a list of co-payments, right? It says like primary care physician, $20, specialist, $50, I don't know, nurse practitioner, $10 or something like that, right? It gives a list of what these fixed payments amounts are. So when you, for example, go to your doctor's office, when you leave for the day, you don't necessarily have to pay for everything that got done or pay for that consultation. You instead pay your $20 because your copayment is the fixed amount you pay for a doctor's visit. It could be $20, it could be $30, it could be $50, it could be $5. But your copayments are different levels that you agree to when you sign up for that insurance plan. So when you sign up for that insurance plan, you're going to get this giant list of services that they cover. You're going to see what your deductible amount is, the maximum amount that you're going to have to pay out of pocket. You're going to see what your copayment is, what your fixed payments are. So how much you have to pay for a doctor visit versus a specialty visit. For example, if you go to a dermatologist or a heart surgeon. Then we also have co-insurance. So co-insurance is a percentage of each bill an individual pays. So sometimes, for example, I just got a cavity filled last week. For my cavity, my insurance company would either pay a fixed amount, so they'll pay $240, which is a fixed amount, or for some dental things, and I've had this for other dental programs before, they'll pay a percentage, a co-insurance percentage. So they'll say, okay, whatever the price of the cavity is, we will pay 75% of it, which means that 25% is the co-insurance that I pay for that cavity. If they cover 75% and I cover 25%, then I have a percentage of the bill that I am paying as an individual. So these are different types of payments that we're going to see on our health insurance bills. Now, when you go pick an insurance plan, they're going to give you a couple options, right? And one of them is going to be, do you want an HSA or an FSA? These are different types of way that you can save money to be able to pay for your medical expenses. All right. The first one is a health savings account. This is an HSA. You probably should just save this video for like whenever you do go to your like real world super awesome job, because like you're going to have to make these decisions. This video will always be open for you to be able to watch. So an HSA is a type of insurance arrangement, right? It's essentially a bank account that you have somewhere of money that you can only spend on medical, right? So when you have an HSA, you typically have a large deductible. So you'll have a lot that you have to pay out of pocket. But this program, you can take your money from your check and put it into your HSA, and it's pre-tax. The taxes have not been taken out on it, right? So this is money that you set aside that you do not have your taxes drawn from. that means you get like an additional what, 20, 25, 30, 32%, depending on what your income is. So these healthcare savings accounts, they're designed to encourage smart health spending without raising taxes. So instead of raising taxes to pay for healthcare, what they instead say is, hey, we're going to let you save for healthcare tax-free, but you have to put it into this type of account. And then you're like, oh, well, that's a pretty good deal. Maybe I want LASIK in a couple of years. I know that's going to be about $4,000. So what am I going to do? Maybe I'll put $4,000 of my pre-tax income into this HSA to be able to use. That's way better than getting my taxes taken out and then having to pay $4,000 to the LASIK person, when really the pre-tax on that would have been like $6,500, right? So it's a way of saving money. But the thing is, this is kind of an expensive tax break because, you know, you're setting aside money for long periods of time that you could be investing or things like that. You may not use all of it. You may use too few of it. It's also a flat deductible. It's not an ideal insurance plan. People tend to not know exactly how much they're going to need in healthcare savings. Like, you don't know if you're going to need $10,000 for an emergency or only a couple $100s for an emergency. So planning out those things can be a little difficult. Now, with HSAs, you can keep this money essentially indefinitely, right? As long as you're working and you have a health savings account, you can put your tax-free money in there to kind of prepay what your deductible amounts are. So this money goes towards deductibles. It's an interesting way of kind of consumption smoothing. So while you're making money now, you can set aside money for when maybe you might be making less later and you need to be able to pay your insurance deductibles. The next version is a flexible spending account. These are called FSAs. Some of you may already have this, and I know a lot of people get mad at the end of the year because they look at it and they're like, oh no, I have to use this money or lose it, right? This is also a type of account where you put in tax-free money, and it's a healthcare savings account, but not, right? It's a flexible spending account. So you put your money into this bank account, and then you can go take this pre-tax money and spend it on different healthcare services. So you can use it on LASIK, you can use it on your co-insurance payments, you can use it on your deductibles, you can use it on other things. And it's designed to encourage people to save for medical procedures. But the problem is, it's use it or you lose it, right? So let's say that I decide that I want to get LASIK next year, and I know it costs about $4,000. I can put $4,000 into an FSA and then, you know, go and pay for it then when I decide to get the LASIK, and we're good. We're happy. It's paid for it, and it's a way that I was able to save money and kind of encourage this savings ahead of time so that I would have enough. But the problem is, it's use it or lose it. You get to the end of the year, and let's say that like I had saved $4,000 in this FSA for LASIK, but the LASIK really only cost me $3,200. Well, then that's $800 that I'm going to lose at the end of the year, which means I need to go frantically spend it on over-the-counter medication or reading glasses or a bunch of other things to be able to use that money, or else it's just gone. So HSAs and FSAs are interesting. FSAs are really, really good if you know about exactly how much you plan to spend in a year and you have a plan to spend that money. HSAs are really good if you want to be able to save for long range medical expenses and deductibles in future periods where you may not have the same level of income. Whew. Okay, so let's talk about the idea of managed care. Managed care is an approach to controlling medical costs by using supply side restrictions. So remember, we have both demand and supply when it comes to healthcare. There's the people who are demanding services or the goods and services. So maybe I broke my arm and I'm demanding to see a doctor. Maybe I would really like for a demand for LASIK or something like that. There's the demand for healthcare costs and services. Then there's the supply side. So it's the people who are supplying these goods and services. The person who's going to be taking the x-rays versus the person who's going to be your general physician who's going to go over your checks and wellness. There's going to be lots of different sort of supply side costs. And due to the supply side costs is how they come up with the medical bills that they then in turn charge to your provider. Now, managed care is an approach to kind of controlling what these supply side restrictions are, right? So maybe we lower the cost by instead with your insurance, you can go see a doctor, but maybe you have to see an in-network doctor. I'm sure you've heard that many times, and I'm sure you've spent many a time looking up on your insurance plan website, like doctors in network around me, that tells you which doctors you actually can go to so that you can pay reduced costs instead of high cost. That's because sometimes with this managed care, different insurance companies will make agreements with physicians like, hey, you're going to be one of our in-network specialists, so we're going to have more people going to your location because you're one of the few people that we're working with. But in turn, I'm going to need you to charge them less. You're going to have to charge them less money, but then I will have more people come to your location. And these are sort of arrangements that physicians and insurance providers get into all the time. So I'm sure when you were picking your health insurance plan, or when you pick your health insurance plan in the future, that you're going to get an option in between a PPO and an HMO. A PPO is a preferred provider organization. So this is a group or a healthcare organization that lowers care costs by shopping for healthcare providers on behalf of the insured. So if you have a PPO insurance plan, that means that this insurance plan goes around and they're like, we know that you will probably need a dermatologist. Well, we've shopped around and we think that these three dermatologists, they're real good. They'll give you good prices. We've already talked to them. They understand that they're going to keep prices low for the people that we're bringing in for them, that we're providing insurance to. These are our preferred providers, and they will ask you to go see one of those preferred providers if you want to keep the cost low. You can certainly see people outside of these preferred providers, but then the insurance will cover less because they don't have agreements already set up with them, so it's going to be more expensive. The next version is called an HMO. This is a health maintenance organization. So this is a healthcare organization that integrates insurance and delivery of care by, for example, paying its own doctors. So a PPO tells you who the preferred physicians for you to see are. HMOs are where maybe an insurance company owns their own doctors, or maybe there's a healthcare group that works specifically with a hospital and employs doctors at that location. Well, then because they have their own doctors, they're able to keep costs very low because their salaries are dependent on this insurance company, not necessarily on the amount of care that they deliver, because they have their own arrangement with the insurance company for what their salary is, regardless of how many people they see. So they can see a lot, they can see a little. And these are arrangements that insurance companies have made with physicians that work specifically for them or with a company that is very, very closely linked to them, right? So preferred provider organization, there's independent physicians that your insurance company prefers you go to. HMO means that there is a set network of doctors who work specifically with this insurance company and that they are paid through a channel from this insurance company or other healthcare system. Woo! All right, so PPOs, HMOs. Oops. There we go. Now there's the idea of prospective reimbursement. There are so many definitions in healthcare, so many. So managed care organizations are paid by prospective reimbursement, not by retrospective reimbursement. This prospective reimbursement means that it's the practice of paying providers based on what treating patients should cost, not on what the provider spends. So for example, you know how I mentioned earlier that I went and got a cavity filled last week and my insurance company will pay $240 for that. Well, that's a prospective reimbursement. That's my insurance company telling the provider that, hey, I have a set amount that I will pay you for this. I will pay you $240. You can spend more filling her tooth. You can spend less filling her tooth, but we are only paying you $240. That's prospective reimbursement. It's not based upon what the cost for the physician or dentist or optometrist is, but it's instead on these set amounts that were provided ahead of time, right? So that's why they'll kind of like prepay for your dental work or prepay for a lot of your physician work instead of you getting a bill months later and then them retroactively paying for it. So payments end up being the same regardless of spending. So there's an incentive to reduce cost, right? For example, if they know that they're going to make $240 from my filling, no matter how much my filling really costs them, then they might use cheaper material or they might do it in a lesser amount of time. A doctor, if they know that they're going to make exactly $600 for stitches and a cast on an arm, and I don't know if that's an accurate number, I'm just kind of guessing at one. If they know they're going to make $600 for that, well, then they're not going to give you like a cool metal shield or something, right? Like they're going to give you something that's cost effective, affordable, and cost them less than $600 because they know no matter what, they're not making more than $600. So they're going to try to keep the cost low. So retrospective reimbursement. This is instead, and this happens a lot of the time when you go out of network to someone who doesn't already have an arrangement with your healthcare provider. These are ones where they instead perform the services and then send a bill afterwards. So you might have to pay it as the patient out of pocket, and then your insurance company will pay them back or pay you back afterwards. So just as retrospective reimbursement offers incentives for excessive care, because if I know that I can do anything and then they will have to pay me based upon that, then I might have a really expensive set of fillings, or maybe, and I'm saying me as if I was a doctor, like I'm a doctor, but I'm not that kind of doctor, right? But let's say I was like the physician doctor, the fancy kind of doctor that's actually useful. I fix economies, not people, but let's assume that I'm an MD. Well, then if it's retrospective, maybe this is someone who's not necessarily in my network, I might use really expensive materials. I might spend a lot of time. I might give them a lot of consulting cards. I might have 3 different nurses work with them so that I can charge them for the 3 different nurses. I might use a lot of materials that are unnecessary because I know whatever that bill is, it's going to get paid back retrospectively later. Prospective reimbursement is instead, I know I'm going to make X amount fixing this arm, so therefore I should keep costs low, right? So let's think about private insurance. So in the United States, we have private insurance and public insurance. So back in 2016, because there's been a lot of changes in healthcare in the past couple of years, and we do not have accurate information on all of it. So we're going to talk about 2016. In 2016, about 2/3 of the U.S. private or U.S. population had some sort of private insurance. So what is that? Like 210 million people or so? Private insurance is either bought yourself as an arrangement in between you and an insurance company or provided through an employer or some other non-group insurance market, right? Non-group insurance markets are just the market through which individuals or families buy insurance directly rather than through a group. So when you go get insurance, you're most likely going to get it through your employer, right? So you go through your employer either pays for it directly, or they have a group plan and you get some money deducted from your paycheck every month to be able to pay to be part of that group plan. There are non-group plans. So let's say that you're self-employed and you need insurance, or maybe you're working retail and you're not necessarily provided insurance through your job. Well, then you need to go purchase insurance. You can go directly to non-group insurance markets and say, hey, Atina, I need an insurance plan. I don't have an employer who's providing it. What will you charge me for insurance plan X, Y, and Z? And then you can choose among those. So why do employers choose to provide private insurance? Because you might be wondering, like, why don't they just pay you more and then they don't have to worry about figuring out an insurance plan? Like, they can just pay you and you can take care of your own insurance and then they don't have to worry about it. Well, it's to pull risk. So insurance companies make good deals with employers, right? So like I work for SIUE, which means there are thousands of employees. Well, out of thousands of employees, most of them are going to be relatively healthy, right? So you're going to have some really risky people or some people that might have high medical care, but then you're going to have a lot of people who don't. So if you pull these people together and you get them signed up for one group plan, then the overall risk level of the group plan is probably fairly low. So when this overall group plan that the school has put together goes to the insurance company, they're able to negotiate lower rates because they have a fairly low risk pool of people, even if some people inside the pool are very, very risky, right? So that's why employers tend to provide your insurance. It's because they can get lower costs. They can do it for cheaper amounts. So instead of them paying you $100,000 and then you having to spend $15,000 on insurance, instead they might pay you $90,000 and have to pay $7,000 in insurance. So really they end up paying $97,000 at the end of the day, and you still get an insurance plan where you make more money at the end of the day than what you would have if you had to pay for the insurance cost out of pocket, even with a higher salary, right? So the goal of all insurers is essentially to create a large insurance pool with predictable risk. As an insurer, I want to know how many people are in my pool, and I want there to be a lot of people in my pool because I know that some people are risky, and I want to have a kind of predictive idea of how many people are going to be risky each year. if I have thousands and thousands and thousands of people, then I can have a pretty rough idea of about 3% of them might get cancer or something like that, or might get some sort of other medical ailment in a predictable sort of way, so that I can start to think about what my costs are going to be as an insurer. This is called the law of large numbers. So you're probably going to hear about that a lot, especially if you continue in on statistics. The law of large numbers is the idea that when you have more and more and more and more and more of something, you essentially get to the point eventually when you have a really, really large pool that has almost everyone in it, you get to the point where things become extremely predictable and that you're able to kind of understand the system better. If I have one person, they might be risky or they might not be. If I have everybody in Illinois on the same plan, well, then I kind of have an idea of about what my insurance costs are going to be based off of just percentages, right? So by pooling all employees, employer-provided health insurance kind of avoids this adverse selection of maybe only the most risky people sign up, right? Because instead, if they have everybody signing up because they give you insurance, so everybody's signing up, then you have the non-risky people who may not have bought insurance on their own and the risky people. So the overall level of risk is probably relatively low. So, for example, well, that's idea one, right? To pool risk. So to keep the average amount of risk low. The second one is because it's subsidized. Why does your employer provide you health insurance, or why will they eventually when you get your big fancy job? Because it's cheaper for them, right? They can get tax subsidies where it's like, oh, well, you provide health insurance to your employees. We're going to give you a tax break for that, or a tax write-off, or we're going to subsidize you a little bit. Maybe we're going to give you some money for this program so that you're able to pay for health insurance. Tax subsidies to employer-provided health insurance kind of looks like this. So workers, you're taxed on your wage compensation, but you're not taxed on compensation in the form of health insurance. So there's kind of a subsidy to health insurance. Let's give an example. Let's have Nancy and Kate, right? Let's say Nancy and Kate, they both have a marginal product of about $30,000. They bring in about $30,000 worth of good to their company, and that's great. Let's say in the first situation, Nancy gets all that money as wages, right? So she gets $30,000 of wages, but her employer does not provide her health insurance. Well, when we take away the taxes, let's say the taxes are like 33% because nice round numbers are nice. Well, then she'll go from $30,000 to $20,000. And maybe a personal insurance plan will cost her $4,000. So at the end of the day, she's going to have about $16,000 in take-home pay that she has after her taxes and paying for insurance. Now let's think about it the other way. Let's say that Kate also has a marginal product of $30,000. She brings in about $30,000 worth of value to her employer. Well, let's say that the employer can pay her one of two ways, right? They can either provide health insurance or they can have wages. So let's say that they decide to put $5,000 into an employer healthcare insurance set and provide her insurance. So she didn't have to pay for that personal health insurance. She has employer health insurance. And then let's say we give her $25,000 in income. Well, $25,000 in income, if we take away 33% for taxes, she has about $16,666 left, right? Okay. And then about $5,000 goes to this employer health insurance. Well, notice what happens here. Either way, she gets insurance. They even spend a little bit more on her employer health insurance for Kate than what they did for Nancy when she had her personal health insurance. But let's look at their after-tax income. Well, in the after-tax income, we see that Nancy actually has a lot less money, even though they had similar marginal products of their labor, right? They both produced about the same amount of value for their business or for their company. But at the end of the day, Kate has more money. Why does Kate have more money? Because her employer paid for her health insurance, which was not taxed. So then the remaining amount of money that she got that was taxed, she ended up with just more money, right? As opposed to Kate, who got taxed on everything and then had to pay insurance on top of it. So this is one of the reasons why employer provided health insurance is so important, is because it's just cost reducing, and it ends out so that you have more money in your bank account at the end of the day. So there's two main parts of federally provided health insurance programs. So we actually have a few others that are very state specific, but the two big ones, the two very expensive ones that you probably know about are Medicare and Medicaid. So let's talk about what Medicare and Medicaid are in the United States. First off is Medicare. So Medicare, this is the one for elderly individuals, right? Or for people who have gone over a certain age or are disabled. Okay, so this is a federally provided program that provides health insurance to all people over the age of 65. So it doesn't matter if you were a multimillionaire or if you were on the streets. You're going to get Medicare when you retire. It's also for disabled persons under the age of 65 who are unable to work. So every single citizen who's worked for 10 years in the United States system and who has paid into Medicare is covered, right? They get Medicare, which is a government provided health insurance for them and their spouse. If your spouse did not work, but you did work for 10 years and you are eligible at the age of 65. This is why a lot of people, even if they have the money to retire at 55 or 60, will delay retiring because they know that they'll lose their health or their employer provided health insurance, and that private health insurance is actually really, really expensive if you're not part of one of these plans. So what they instead will do is just kind of delay and wait to retire until they're 65, where they get their government insurance, right? So Medicare is financed through a payroll tax on employees and employers. So you've probably seen this at the bottom of your paycheck stub. You see that you're going to have a section that says like FICA, and part of it goes to Medicare, right? This is a payroll tax that's paid half by you and half by your employer. This money is bundled together and given to the government, which instead pays for this insurance for people who are over the age of 65 or in this medical program. This is the largest public health insurance program in the United States. So it's all administered at the federal level. So the federal level actually controls where this money comes from. So it collects all the money and then it distributes the money as payments to different sort of doctors and providers and nurse practitioners and things like that. It's all administered and run at the federal level. So all U.S. citizens who have worked and paid payroll taxes for 10 years are eligible. Ineligible citizens, so people who may not have worked 10 years or may not have worked legally for 10 years, they can also purchase Medicare coverage, but unfortunately it's going to be at the full cost, right? So they have to pay for the full cost of the program as opposed to just receiving it in exchange for the FICA taxes that you had paid and the payroll taxes that you had paid during the time in which you were working for those years. So there's really 3 different programs. Technically there's a Medicare Part C, but it's just so rare and no one uses it that we're not even going to mention it. So really there's 3 different programs inside Medicare. So this is the stuff that you probably hear about on infomercials, especially like daytime infomercials that are like, if you're part of Medicare Part D, you are available for this drug or prescription, right? Let me explain to you what the different parts of Medicare are, because this is just important to know. Medicare Part A, so the first part, this is the part of Medicare that covers inpatient hospital cost and long-term care. So it's financed completely from the payroll tax, and this pays for like if you need to be in the hospital for extended period of time, and this pays for if you need a lot of surgical costs or have an emergency room visit that's going to keep you in the hospital for a while. That's Medicare Part A. It pays for those things. Medicare Part B is the part of the Medicare program that covers physician expenditures. So this is the visits for your doctors, outpatient procedures. So for example, if you need to get your sinuses worked on or something like some shots, or maybe get like a wart removed, outpatient things, or physician things, or other types of services. For example, like I used to go get allergy shots. That would be covered under Medicare Part B if I was over the age of 65, right? It's financed from enrollee premiums and general revenues. So the general amount of money that the program makes, and also from small premiums that you can pay to be part of Medicare Part B. Okay, then finally is Medicare Part D. Medicare Part D is the prescription drug expenditures portion, right? So this is money that goes into the system to be able to make drugs affordable for elderly individuals. So if you're over the age of 65, you get reduced cost on Schedule 2 drugs, Schedule 3 drugs, antibiotics, generic, brand name, so on and so forth. And a lot of that comes to the fact that there's this Medicare Part D program that if you enroll in the Medicare Part D, it makes it so that drug expenditures are less expensive for you. So that's Medicare, right? That's just kind of the overview of Medicare. And Medicare is for elderly individuals or disabled and unable to work individuals. The next one is the idea of Medicaid. So Medicaid is another federal program, but the difference is this is a federal program and that gives money to the state programs, and then the state kind of manages it from there, right? So the purpose of Medicaid is to try to help very specific groups who need help in the United States so that they're able to afford medical services. Some of these are people who qualify for cash welfare programs. So welfare programs in which the state has decided to give cash to someone to be able to like help them through tough situations. They want to make sure that you're medically healthy so that the money can be spent on the things it's meant to help you with and not on medical bills, right? So they try to provide health insurance for this. Most low-income children. So it turns out that we drastically save money in the United States if we provide like a minimum level of health benefits to every child, so that they're healthier and then they have less poor adverse outcomes later on in life that might be really expensive, right? So they try to, Medicaid gives money to poor individuals who have cash welfare programs, low-income children, low-income pregnant women who may not otherwise be able to afford maternal services, very low-income families, and low-income elderly and disabled people beyond what is just Medicare, right? Because sometimes you have someone that's so impoverished that they need additional help beyond that. So federally mandated, state administered. The money gets collected by the federal government. It's given to states. States can make a lot of decisions within that. For example, what the federal poverty level that they accept is. Some of them accept 100%. Some are 175%. Some of them are 215%. Actually, I don't know if that last part's true. I think there's one that's 215% of the federal poverty level, but I would have to check. So severe low-income families. So people who are below the federal poverty line, or for most states below 175% of the federal poverty line. So I think the federal poverty line is like 15,000, so about 23,000 people who are below this. Our families that are below this can have different parts of Medicaid to be able to provide them insurance when they are unable to otherwise afford it. So severe low-income families with different thresholds have different thresholds in each state. One of the most important pieces that are provided by Medicaid is the Children's Health Insurance Program. We call this CHIP. You've probably heard of CHIP at some point. This is a program that started in 1997 to expand eligibility for children of public health insurance beyond the existing limits of Medicaid. So in most states, if you're below 175% of the poverty line and you're an adult, you're not going to be able to get Medicaid. But the thing was, there were a lot of families that were just right on the cusp. They were right above this amount, and their children were going hungry, and their children weren't getting like proper physician visits to be able to avoid preventable diseases or to detect very preventable cancers or things like that. So the CHIP program makes it so that families up to 200% of the federal poverty line, those children can still receive public health insurance and still be able to see government-funded doctor visits, right? So what are the rules? Everyone 18 and younger up to 100% of the poverty line in the United States is available for this. Children in the age of 6, pregnant women, they can get covered up to 133% of the poverty line. In most states, eligibility is actually above this because the states have said, wow, turns out 100% of the poverty line is like a very, very small amount of money. So maybe like 150% or 175%. That might be something more reasonable to try to cover people under that, because if you have $25,000, $30,000 for a family of 4, you're probably not able to afford very expensive private insurance for everyone, right? So in most states, eligibility extends further for both children and pregnant women, and typical states cover children and pregnant women up to 200%. And this was a massive expansion of the Medicaid program that was put into place by the ACA. So currently 18 states have opted out of the expansion of Medicaid that was provided through the ACA. So this was even more money that was available for poor individuals. A lot of states have opted out of taking this money because it's a lot of administration cost, or maybe they don't necessarily want to prioritize helping certain groups, so they've decided to opt out of it. But most states have taken this Medicaid expansion where there's more money coming in from the federal government to try to be able to help at-risk families. So what kind of health services does Medicaid cover? It's required to cover physician and hospital care. So if you have to go to the doctor for things like your general wellness visits, but also like if you break your arm, or if you need stitches, or if you find a lump somewhere, it's required to cover these sorts of things. And it also covers dental and prescription drugs. So it doesn't matter if you send someone to a doctor and they really need a medication to get rid of a disease, and they can't afford the disease, then seeing the doctor doesn't really help if they still have the disease and they can't address that, right? So it covers prescription drugs so that they're able to get the medication that they need. And it also helps with dental, because it turns out that a little bit of preventative care, small upfront cost on preventable dental care can actually drastically help people in the long run from having to pay tens of thousands of dollars in root canals or dentures, so on and so forth. And how do these providers end up getting paid? Well, the money goes into the federal government. The federal government makes these payments to the states. In most states, Medicaid reimbursement is relatively low, so there's going to be certain doctors who agree to take Medicaid patients, and the states pay these patients though for relatively low amounts for these services, right? So they might be like, okay, we know that you're filling cavities, but we can't afford $240. We can pay you $100 for every cavity that you fill for one of these people, right? So some physicians will refuse to see Medicaid patients because even though these are low-income individuals who desperately need help, some doctors look at the payments that they can actually get from the Medicaid program for seeing these patients and realize that it's a very low amount and that they might be able to make more money elsewhere, so they refuse to see Medicaid patients because there's just not a high reimbursement rate and they're going to lose money. So how does Medicaid affect health? Does Medicaid increase insurance? And between 1982 and 2000, we saw huge increases in program eligibility. This is when we started making it in some states so that there's an increase above the federal poverty line of households that were able to have Medicaid. So lots of new people could get Medicaid, but only about 10 to 25% of all these new people, when we increased the program eligibility, actually signed up for it. So if there's a whole bunch of new poor people who now can get this federal program that's state administered, why did only 10 to 25% sign up? Well, because there was this crowd out idea. Many new eligible people did not sign up because they already had health insurance. They might be extremely low income, but maybe they did have some sort of employer provided health insurance that might, even if they're making low amounts of money, right? But what we did see is that many ended up dropping their private coverage, right? So some people who, for example, maybe they made $30,000 for a household of 4, and they were spending $8,000 to $10,000 on getting insurance for this family of 4. Well, that means at the end of the day, they have $20,000 to $22,000. That's not much. I don't know if you all have tried to feed a family, but that is expensive. And there's like rent, and rent's really expensive. So $22,000, like that's not a lot to pay rent and feed people and try to get school clothes and things like that. So a lot of people dropped this private coverage that they were spending this $8,000 to $10,000 on, and instead moved over to the Medicaid system because maybe the benefits under Medicaid were more generous, and because it allowed them some financial benefit, right? But we only saw that this happened for about 20 to 50% of people within this category that were eligible to do so. So the crowd out actually wasn't that bad of people who were giving up their private insurance to try to get this public insurance. So who are the uninsured, right? This is something that we think about in the United States all the time, especially, I mean, I don't know if you all have been listening to the news, but it's something that's been coming up frequently as we've been talking about different sorts of healthcare in the United States over the past couple of years. So there are currently about 28 million people in the United States without any insurance or coverage whatsoever. These individuals who are in this uninsured class typically have lower than average incomes, so they're typically close to the federal poverty line or are under the federal poverty line. In 2016, 3/4 of the non-elderly uninsured people came from families where more than one member was working full-time. So it's not that these are unemployed households. There's generally someone who's working in this household, but it's for a very low income and they're not necessarily able to afford insurance. And about 13.3% of all the uninsured, of the 28 million uninsured people, about 13.3% of these were children, right? So why might they be uninsured? Well, there's a couple different reasons why a family might choose to be uninsured, right? One may be that they're counting on uncompensated care. So the uncompensated care is the cost of delivering health care in which providers are not reimbursed. An emergency room, if you're having an emergency, has to see you. They can't say, oh, wow, you're having a heart attack, but we don't take your insurance. Or, oh, you're having a heart attack, but you don't have insurance. You got to go. That doesn't happen, right? So some families or some people who have decided to be uninsured have assumed that, okay, if I am in that position where I am having that much of an emergency, the hospital will have to fix my problem, and then I will just not pay the bill when it comes in. This actually happens a lot. Of uninsured individuals who go to emergency rooms, a very low percentage of those bills ever actually get paid. And then there's a lot of people who kind of just make the decision because insurance is costly, right? They might be making some amount of money and they might be above the federal poverty line, but still low income. And they look at it and they say, you know what? I don't know if I really want to pay $500-600 a month when I can barely afford like food for my family. Maybe this is just too expensive. We're all relatively healthy. We can go a year or two without insurance. That's a decision that lots of families make on a very regular basis. Also, insurers may be unwilling to insure people with the worst risk, right? Sometimes they worry, or the insurance companies worry, that only the people who desperately need insurance are going to be the ones signing up for it. This is why the debate on covering pre-existing conditions is so important. That's because can the insurance company say no to someone because maybe they've had a child, or maybe because they've had cancer, or maybe because they've had an expensive disease in the past, or maybe because they have diabetes or something that the insurance company knows is going to be expensive over a long time. So sometimes these insurance companies are unwilling to fund certain groups because remember, the purpose is to like pool risk and to have like a low average amount of risk that's predictable. So sometimes they don't necessarily want to give insurance to people that they know is very likely to be more costly than what money they're going to get in, right? So they might be unwilling to insure some of the most risky people. And then a lot of people just don't appropriately value insurance coverage. Why are a lot of uninsured people between the ages of like 18 and 22 and perfectly healthy? Because they're between the ages of 18 and 22 and perfectly healthy. They tend to undervalue what these insurance coverage means to them. They look at it and they say, I can pay $400 to $500 a month for insurance, or because, I'm 18 to 22 in this hypothetical situation, so I'm probably not making a ton of money. Instead of spending $500 a month, you can say, well, I'm probably not going to get that much benefit from the insurance. So instead, I'm just going to go without it. Even though they tend to undervalue what the actual use of that insurance will be, because people who are young and healthy tend to assume that they're always going to be young and healthy, and they don't have an accurate perception of what their healthcare risks are, right? So there's lots of reasons why people might choose to be uninsured. And then you might wonder, so why do we care about them? Right? So they may not be planning to pay bills. They may not just be able to afford it and decide that it costs too much. They've made this valuation for themselves because they weren't appropriately thinking about what their healthcare costs could be. Why do we care? Well, because there's physical externalities associated with communicable diseases, right? If there's a whole bunch of people who decide to be uninsured, so they don't go get flu shots and they don't get other communicable diseases such as like tuberculosis taken care of, well, then there's physical externalities, right? They're much more likely to give it to the people who have insurance. If there's a lot of uninsured people who are not getting their healthcare costs taken care of, or their preventable healthcare taken care of, then it's much more likely that you're going to get sick, or that other people are going to get sick because you have a pool of people who are not having this easy and cheap preventable help that they could be having with an insurance plan. And therefore, if they're in a more risky situation where they do have communicable diseases, it might physically affect everybody else by giving them communicable diseases. So that's also very financially worrisome, right? Because that raises the cost of healthcare, not only for those uninsured individuals, but for all the insured individuals as well. There's also significant financial externalities imposed by uninsured on the insured. So I had mentioned that lots of different people count on uncompensated care because they know they're going to go to the emergency room without insurance for a broken arm. And then what is a broken arm? Like $11,000 in non-insurance costs. So the bill at the end of the day is going to be $11,000. Who's going to pay $11,000 for a broken arm if you can already barely make your rent, right? So because these bills aren't necessarily paid, that means that there's a lot of costs that the supply side has had that aren't necessarily compensated. So they're going to have to raise the prices on everything else. The prices go up. That means that the amount that they're charging insurance goes up, which if insurance is having to pay more, the cost for you goes up, or for the insurance holder goes up. So there's physical externalities, there's financial externalities. Care is not delivered appropriately to the uninsured. If you're uninsured, there's many things such as like flu shots and tuberculosis checks and stuff that you're just not getting, or you don't have the availability to get, which makes the other two even worse, the financial and the physical externalities. There's also paternalism and equity motivation, right? We don't like as people to see sick and suffering people. So there is some sort of motivation as a society to say, you know what, okay, maybe we help this group, and like you don't have to raise them all the way up, but like make it so like they're not sick and suffering. There's a paternalism need there for many people when it comes to equity to provide a bare minimum subsistence for people. Now, another thing that's kind of a reason why people should worry about the uninsured is because becoming uninsured is a huge concern, right? Let's say that this is 5 years from now. You've graduated from public economics and you know a lot about externalities, and you have a super awesome job. You're making like $100K a year, and you're well respected by your peers, and you have a great health insurance plan through your work. But there's always the chance that you could lose your job, right? And you could lose your job, and at the end of the month you don't have insurance anymore. And what are you going to do in that situation? Maybe it's a bad economy, or maybe there's a pandemic and you won't immediately be able to find work afterwards. So that means that you're going to have a period of time uninsured. Well, since there is a chance that you will become uninsured, then maybe there's a value to also having a plan for what happens to the uninsured if you have a chance of being uninsured. Now, one thing that people do point out that they worry about in this is job lock. So there's a lot of people who kind of get stuck at the job that they're in, and they get stuck in jobs that they hate. Like they would much rather go work for somewhere else, or they might much rather join a nonprofit and try to save the world or something like that, but they can't because their job provides them insurance. I can name like 6 professors who work because they get insurance, right? And they're kind of like stuck in those jobs because it provides your insurance. And if you try to leave that job, you're not going to have insurance anymore, and medical costs are very expensive. So it kind of locks people into place, and it reduces your mobility or your ability to change jobs in the future. And that's something to be worried about, because it limits your socioeconomic mobility, and it limits your ability to chase after your own happiness, right? So then in 2010, we get the Patient Protection and Affordable Care Act. I'm just going to call it the ACA because everybody else calls it the ACA. It came into law in 2010, and it made 5 fundamental changes to the U.S. healthcare system. So the U.S. healthcare system had a lot of back and forth. There were some good parts, there were some bad parts for a long time. And then in 2010, we got the ACA. A lot of people refer to this as Obamacare, right? And it made 5 major changes. Right? The first is it banned insurers from denying coverage because of pre-existing conditions. So like if you had cancer previously, or you had a child or something like that, they couldn't not cover you. It also banned insurers from charging different prices to different people based on their health, except for smoking. I think you could still charge more to smokers, but you couldn't go to someone and be like, well, you two are the same age, the same weight, the same background, the same parents, but you had cancer and you didn't. So I'm going to charge you $3,000 and you $1,000. You couldn't do that, right? You couldn't charge people different amounts based upon their health. It also mandated that, and this was a mandate that eventually went away, but at first it was a mandate that everybody had to have health insurance. So everybody in the United States had to have health insurance. What we ended up finding from this one is that a lot of people were very unhappy, right? Because there were some people who chose to be uninsured. They're like, you know what? I'm healthy. I'm okay. I'm very unlikely to get sick this period. I do not want to pay for health insurance. And then all of a sudden, these people had to pay for health insurance, which could have been expensive. All of a sudden, they have a $400 or $500 bill every month that they were just kind of like risking and deciding that they didn't want to pay because they were undervaluing their health expenditures. And now all of a sudden, there's more money that they're having to pay. That's very unpopular for some people. And it's very expensive for some people who are low risk, who wanted to make that choice for themselves. So it did mandate that all U.S. residents had to cover health insurance. Now, why do this, right? Because notice the first two. In the first two, we're now having people with pre-existing conditions. So this is the highest risk category. And people with high risk or adverse health conditions are also being charged the same amount as the healthy people. Well, that means that costs are going up, right? So instead, if you mandate that everybody has to have health insurance, well, then it comes to the idea of pooling risk. If you get everybody involved in the system, then even though we have these very risky people who now have to have coverage, there's now an even bigger base of healthy people to kind of balance out that risk, right? So that the cost is more predictable. So that's why there was the insurance mandate. It was so that you could have a bunch of healthy people who otherwise would have chosen to not have health insurance to offset some of these costs from people with pre-existing conditions or other medical issues. Then it required that federal government extensively subsidize health insurance coverage for the poor. This is where you got the healthcare.gov website that you could go to, and you could put in your income level and a little bit of information about yourself. It'd tell you what your government subsidy would be that would be able to pay for part of your insurance premium, and then it'd give you a selection of insurance plans that you could choose from. That would be like, for example, $300 a month insurance plan. If you were available for, like, let's say $170 subsidy, it'd say $300 insurance plan, $170 subsidy, and then at the end of the day, you would pay whatever that difference is. So maybe $130, and that's what you would pay every month. And that was more based upon what your finances were. The poorer an individual was, or the lower their income, the larger and larger the subsidy would be, right? And then it took a variety of actions to lower healthcare costs by, like, negotiating with different hospitals or coming up with different arrangements. So I'm fairly certain that everybody who watches this is aware that there's an impasse over national health insurance, right? And I'm not going to tell you how to think. It's up to you to figure out how you think. Because in public economics, I teach you the tools. Your opinions are your own. But what we've seen so far is that some people do argue for a single payer system. They say, you know what, we may get less research and development, and we may get kind of increased healthcare costs for people that otherwise would have decided to defer from healthcare, or people who might have deferred for lower plans. But maybe we still want this because government provided health insurance for all guarantees full coverage, and it lowers the admin cost, it eliminates some of the inequality, and it causes a straightforward budget so that we can make arrangements with every hospital, and it's cheaper. But there's some disadvantages too. So some people argue for that. And then some people point out the disadvantages that come along with that. It dramatically increases the government expenditure. So the government's spending money. It's no longer people spending money, it's the government spending money, right? Even if we all pay money into the system, that's not always a one-for-one situation, and there might be more money that's being spent at the government level. Budgeting is also a blunt instrument. If we all of a sudden have one budget where we say, okay, every single doctor in the United States can only charge so much for a broken arm, well, the thing is, this is going to drive down people's want for costs, right? So if we say that we will only pay $600 for every single broken arm, then there's no doctors who are going to want to use the fancy technology that, like, 3D prints a perfect cast that molds just to someone's arm. You may not have this use of technology or this use of research and development that we would typically have, and that's where we get a lot of the medical innovations. Then there's also a lot of political hurdles for insurance companies, right? Insurance companies would then know that people either wouldn't use private insurance or are less likely to use private insurance, so they would have to massively downsize and lay off lots of workers. or they would have to work with governments, of which there's many different political atmospheres that might have different feelings towards still maintaining a relationship with private insurance when there's a single payer system available. So there's good, there's bad, and there's different opinions in between, right? But what have we seen? What have we seen since the time when the ACA came in? Well, the percentage of uninsured individuals has gone down, right? It stayed relatively flat the past few years, but it has gone down where more people have insurance today than they did back in 2008, right? Some early evidence of the ACA is that the number of uninsured kind of fell. I don't know where this is filled. I must have been tired. The number of people without insurance fell by about 22 million. The uninsurance rate declined by more than a third. This actually ended up saving money because a lot of these uninsured people were either not paying their bills or that they were on like other government programs where we could spend $1 for health insurance, giving them health insurance, and it saves us like $5.7 later on in future healthcare costs because you spend $1 on the preventable piece and then they're healthier overall. So they're less likely to get these really, really expensive adverse outcomes that would have cost the government more money. So it's actually cost savings in a lot of ways too. Some studies suggest that this coverage has improved access to care and self-reported health. So people are much more likely to self-report their health outcomes, decreased emergency room use, increased use of preventative care. I also spelled use wrong here. What was I doing? And then cost growth since the passage of the ACA has been rather low. So costs have gone up. They've clearly gone up. They've been going up by small amounts each year. So there's lots of really interesting and fascinating parts of the health insurance system in the United States. I'm not a health expert, right? We have Ari Bellison in the department. We have Marlon Tracy in the department. They are both fantastic health economists. So if you ever want to work with them or take classes that are devoted to what we've covered today, those are the people to talk to. But it's an interesting system, and there's a lot of pieces that are happening there and a lot of moving parts that we don't necessarily think of. Because I mean, before today, how much did you think about the exact administration cost of even processing your bill at the doctor's office? I mean, that can be very expensive and difficult. So there are things that we have to think about as we address different ways to take on healthcare. And we don't have a good answer. That's the purpose of public economists, is we're supposed to look at all the different options and kind of weigh the goods and bads of each one. Thank you so much. I will see you all in class. And wow, can you believe we're already at week 10? We're getting there. Remember, on the 11th of November, the rough draft of your presentation is due. Also, by that time, you need to sign up for a presentation time slot with me. Okay, everybody have a great day. Bye.